let's get started with the reproductive system.
All right, so starting points. We are going to review the normal physiology of male and female reproductive systems. I'm going to break it into basically female first, and then we'll go into male and pathology, pathogenesis, and pathological changes per each one. Obviously, our main function is reproduction, and we are forming a 46 chromosome zygote. Remember that we have 23 from mom, 23 from dad. Lots of steroid sex hormones, which we're going to be getting in tonight with support from other hormones. And then we still have that endocrine influence, right? So when we're talking about endocrine influence here, we're talking about the HPG axis. And that is basically your hypothalamus to pituitary and then gonads, all right? And that's basically the reproductive. So HPG axis, it is under endocrine influence, and we're going to get into that in a moment here. So when we're talking about this, we have gonadotropin releasing hormone, and that starts basically at age 8. The hypothalamus increases the production of it. So we have the gonadotropin releasing hormone from your hypothalamus, which is up here, comes down the pituitary stalk into our anterior pituitary, and then we get LH and FSH, all right? Now, both of them are going to be released and worked on both, okay? So LH and FSH will work on the testicles of the male, and they will work on the ovary of the female. So both of these come out of the pituitary and work in both male and female, all right? So what does it do in the male system? So when we look at it, it's going to go down, and actually you're going to basically have two real main things. So we're going to have testosterone, and then we're going to have spermatogenesis. All right, so those are basically the two things that we're going to get out of this situation. The testosterone is then in charge of getting us our secondary sex characteristics, as well as really influencing spermatogenesis. The influence of the testes will then potentially lead to infertility if we have problems with testosterone, as well as anything in the primary gland, which is the testes. So what are those secondary sex characteristics? Basically making more adult-like features, such as making the penis and the scrotum grow. We get facial hair, we get that lowering of the voice, basically shoulders broaden, really getting those masculine features. And that's what basically makes that testosterone, all right? And then obviously spermatogenesis, we need this for fertility and what we're talking about, reproduction, all right? So that's basically the effects of LHS, and we're going to go a little bit more in depth into that in a little bit, all right? That's just kind of an overview of it. So then we have LH and FSH and their effects on the ovary, all right? So ovary, we're going to have estrogen release mainly, as well as then progesterone. But when we're talking about this kind of scenario, the estrogen is the key that is going to develop our secondary sex characteristics in the female, which is breast development and maturation of them, hips broaden, pubic hair grows. So really giving the more feminine features that we get with that, and that is estrogen. The thing that we get here is follicular genesis, and that is basically ovarian maturation of an egg. So that's going to be what follicular genesis is, and we're going to go into that as more. But understanding that broad overview, really kind of two main things that are coming out. Estrogen here, and then follicular genesis over here. Same thing, testosterone and spermatogenesis when we're looking at the male. So we talked a little bit about the endocrine, as well as we do have neurosecretory cells as well. So remember we talked about how in neuro we have that excitatory or inhibitory response that comes down the neuronal cells. So that also plays a lot into this, and that's what they mean here with neurosecretory cells. So whatever that stimulus is comes down and then may trigger an endocrine or a reproductive scenario. What I want to focus on in this slide are these two as well as this one. So don't worry about this. We talked about most of them in endocrine. So this is more of the endocrine right here. This is going to be more repro. And this is repro over here. All right. So basically these are up in the hypothalamus. We have some type of stimulus that comes down from our neurosecretory cells and stimulates one of these things to happen. So what I want you to see here is that we have PRH and PIH. So what does that mean? So this is prolactin. All right, so you can see here our pituitary hormone is prolactin. Well, this is prolactin releasing hormone. You see there's a plus here. So you have prolactin inhibiting hormone, which is actually dopamine. This is actually estrogen over here. So what does that mean? Well, if you think about it, so we're not pregnant all the time. We're not having babies all the time. So we don't necessarily want to have prolactin being stimulated all the time. So most of the time when we're not pregnant and not getting ready to facilitate feeding our child, we are actually under inhibition for dopamine. So dopamine is actually suppressing the prolactin, and that then basically stops the prolactin. We don't have it, all right? So that's what's going on here. Now, once we get pregnant and we have all the hormones and we get ready for basically being able to breastfeed, then we have releasing hormone, and then we will have stimulus from the anterior pituitary to release the prolactin and work on the breast to facilitate the mammary glands. So that is there's an inhibitory hormone, and that's most of the time except for when pregnant. And then we have the releasing hormone when we would be pregnant. Now, when we go over here to gonadotropin releasing hormone, which is what we do basically to get FSH and LH, you can see here it is always positive. So if there's stimulus coming in for that gonadotropin releasing hormone to be stimulated, it's always going to be a plus, meaning if it's stimulated, we're going to get LH and FSH released. So then you can see here that LH and FSH work on both gonads, which we just talked about, and then we have basically these hormones that are going to come out of our gonads. So estrogen and progesterone, as well as androgens, which is basically testosterone. All right. So just be aware of that. And, prolactin is kind of, is a, an individual one here. But as you can see here with growth hormone releasing and growth hormone inhibiting, that's the same kind of scenario, and that's more on the endocrine side. All right, so next up is differentiation and hormone production in utero. So this is just something to be aware of and understanding how we get embryonic development. So you have both male and female embryos that are homologous. They can contain that one pair of primary sex hormones and two pairs of ducts. So very important. So one pair of primary sex organs, two pairs of ducts. Well, what does that mean? So let's take a look here. So what you have here is a picture of basically a 5 to 6 week old embryo, sexually indifferent at this time. All right. So here is the mesonephric, which is the Wolffian duct. And then here is the paramesonephric, which is the Mullerian duct. So you can see here that the Mullerian duct is the tiny pink one here. And then the mesonephric, which is the Wolffian, kind of has the finger-like projections there. So what's the big deal? Why does this matter? Well, what happens in utero, and as we're developing around 5 to 6, we will either have the influence of this protein or we don't have the influence of this protein. This is what determines the sex of the baby. So as you can see here, we have both abilities. So we have both, we can make this into any sex, male or female at this time, because we have both of these Wolffian or Mullerian ducts. It all depends if we get SRY protein or we don't get it. Then we start differentiating into our female and male reproductive system. So as you can see here, we have no SRY, and then we're going to start differentiating into the female. So what happens is we start degenerate the Wolffian duct. The way I memorized it is wolf, more manly. So Wolffian is going to be the male testes. So what happens here is, so we have this pink thing here. Here's the pink thing again. All right. So that is the Wolffian duct. It's up here. We're not going to use it because we actually start losing it. We are degenerating it in preparation to facilitate a female anatomy. So what happens then is basically the paramesonephric duct starts to form the uterine tube. As you can see here, the paramesonephric is the Mullerian duct. So your Mullerian prevails, we lose the Wolffian. So it goes away, it degenerates. So that's what happens in female. So you see by 8 to 9 weeks, the female fetus is basically pretty well on its way to being differentiated. As you can see, then we also get the forming of the uterus. We move our urogenital sinus as well as our bladder moves to the side. And you can see this clear, classic, now female anatomy down here. Classic uterine tubes, your ovaries, uterus, cervix, vaginal canal, and there's your bladder. Now, vice versa, we do have SRY protein, which means that we're going to have male formation. So here is the paramesonephric duct is degenerating. So now over here, the pink, which was here, now this is going to start degenerating, and we lose that. And that is the Mullerian duct starts to move away. The other duct, which is the Wolffian duct, and that was the finger-like projections, starts transforming, and then we get the sperma vas deferens and the differentiation into the testes, and then as you can see here, then we have descend of the testes. You can see the difference in the bladder as well. So you start to have that urogenital sinus that forms the urethra, and it's much different than the female anatomy over here. But as you can see, you have them both up here at 5 to 6 weeks. They differentiate after they get this protein. Positive, the Wolffian duct, we are negative Mullerian, basically meaning it's going away, degenerating. So that is what basically differentiation of the hormone, differentiation and in utero. So here, all embryos are inherently female, but they need the SRY, and they have the ability to do both, but they need the SRY, which is on the Y chromosome. And that's what basically says that you're going to have male development. Here's everything that we just talked about. Both ducts empty into that urogenital sinus. So around the 4th to 5th weeks of fetal life, that anterior pituitary is pretty well developed. By 12 weeks, there is a clear, distinct connection between the hypothalamus and the pituitary. So that's why endocrine, reproductive, and neuro intertwine when we're talking about that. So then, obviously, we're going to have lots of FSH, LH. There's another one called gonadostat. So this is gonadotropin releasing hormone pulse generator. So this is, we get lots of pulses, gonadotropin releasing hormone, and it's a more pulse. Once we hit puberty, then it's more constant. All right, so that's important there. But those basically are the hormones that you're going to see, which makes sense because in development, basically the production of the FSH and LH rises, so it increases till about 28 weeks, and then we start getting estrogen, progesterone, which then reduces, so that feedback system, and kind of turns off the GnRH. We're talking about sperm production over here. This actually for the male actually begins at puberty. So big difference between female and male reproductive start times. So by the time that the birth of the female happens, we already have all of our eggs in that early stage, that primitive ova. Sperm does not start until the male is at puberty. All right. So hormone production, FSH, LH, GnRH, that gonadostat, progesterone, estrogen are pretty much what you're going to get in utero. All right, moving on. All right, so what's very important is just kind of knowing locations. So we have all that influence from the hypothalamus, but now we're talking about the gonads. We have a lot of production of our hormones actually in the sexual glands themselves. So when we talk about the ovary, what's coming out of it? So we have progesterone, androstenedione, estrogens, and inhibin. When the female becomes pregnant, then we have progesterone, estrogens, HCG, human placental lactogen, and inhibin as well. just for the uterus when pregnant, we would have prolactin and relaxin. And we're going to go into all of these into more in depth. I just wanted to kind of give you the overview of where they're located. And then obviously testes, the male organs, are a lot less complicated if you want to look at it that way, but androgens, estradiol, and inhibin come from the testes. All right, so that's just kind of an overview, and now we're going to go into them. Reproductive hormones, LH, FSH, GnRH, estrogen, testosterone, progesterone, and there's a couple others that we're going to talk about. So basically control the reproductive axis, which is correct, right? That's what we're talking about here, is that axis, so the HPG axis, and periodic pulsatile release of GnRH. All right, so then in response to that gonadotropin releasing hormone, basically pituitary releases the gonadotropins, which is LH, FSH, into the bloodstream, travels to the gonads, and then we get the production of these other hormones. All right, so that's just a synopsis of that picture I just have shown you. So now we're going to look at the summary page. All right, so I put this online, so if you have not printed it out, go ahead and print it out, pause the movie, go print it out, and then I would print 2 copies because there is a lot of writing here. So as you can see here, we have action male, action female, and we're going to go into all of this right now. So what I want you to do, go print that out and then come back and we'll get started with the reproductive hormone summary. So we're going to get started with male first. So DHEA. So this is a very long one. So this stands for dihydro epi androsterone. So that's why we call it DHEA. All right, so the source is the adrenal gland, ovary, and some other tissues. So obviously we're going to focus here the adrenal gland for the guy because the guy doesn't have any ovary. So a lot of this comes out of the adrenal gland. Remember we talked about that briefly, where there was a little bit of extra hormones that came out of the adrenal gland that consisted related to reproductive hormones. Well, this is the precursor. So what does this basically do? So this is kind of the precursor. So we get the DHEA, and that is going to go into androstenedione. And then that is actually going to get converted into either testosterone or estrogen or both. All right, so that's basically its job. All right, so it's the kind of the precursor that can be changed into any of the sex hormones. So this is going to be important because this happens in both. All right, so both female and male. So I'm not going to write that over again when we get to action female, other than reminding you that this is the same for both female and male. Basically, adrenal gland, obviously in the female it would be ovary, but the adrenal gland mainly for the male. And it's going to be a precursor, and then we have transformation into our sex hormones. All right. So then for the action of the male of estrogen. So what happens with estrogen in the male? So we talked about estradiol being in the testes. So that is going to be in charge of basically growth. And that's at puberty. And then also fusion of some of the growth plates. And then actually prevents apoptosis of the germ cells. All right. So now we go into testosterone. Adrenal glands come from DHEA, which we just talked about, and then for the female it would be the ovaries, which we're not talking about right now. So for the guys, we have the DHEA adrenal glands, and then we have the influence to the testes, right? What is this going to do for the guys? So big list, okay? So I'm going to start over here. So this is testosterone. Spermatogenesis. Stimulates primary and secondary sexual characteristics. Muscle growth, lean muscle mass, and bone growth, and this is called anabolic effect. And then it also axillary hair, pubic hair, basically all those secondary sexual characteristics. And then this is the result of acne in men. This causes acne in men. And then it maintains libido. So testosterone, very important for men to basically maintain the ability to reproduce, as well as their characteristics that are male characteristics and basically a virilizing characteristic. Lack of testosterone, we have more of a feminizing, and we lose that virilization. And so I did recently have somebody who had testicular cancer and then basically got testicular cancer in the other one, so had radical orchiectomy, and did not want to be placed on testosterone replacement therapy. So over the years of having very low, non-existent testosterone, I believe his levels were pretty much non-existent, he did manifest more of a feminizing, a more non-virilizing look to himself. It's very interesting. So testosterone, very important for the male to kind of maintain that physique, the ability to reproduce, as well as libido and spermatogenesis. So gonadotropin releasing hormone, so that's the one that's at top. So we know that that is basically what's going to stimulate the pituitary, and then we're going to get LH and FSH, which starts the whole process. So we go into FSH and for the male side of this, so what does basically FSH do for the male? We are going to work on the Sertoli cells, and we're going to get spermatogenesis. Also promotes testicular growth. So then luteinizing hormone comes from the anterior pituitary, just like we talked about earlier, as well as the gonadotropin cells, which are going to be more localized. And so what are we going to be doing here? So this is actually the Leydig cells in the testes. And here you're going to get testosterone production. And that is basically what happens with that. Now, inhibin. So inhibin for the man is basically going to inhibit FSH. So if we're inhibiting FSH, so we're going to inhibit spermatogenesis. So if inhibin is activated, we're inhibiting spermatogenesis. Inhibit FSH at the pituitary. So that is the male side of the reproductive hormones summary. Okay, so now we're going to look at the female side of these hormones. So just remember that when we're talking about the female, the DH did the same thing. All right, so DHEA to the androesterone, and then we get testosterone or estrogen or both. So now, obviously, the big one for female is estrogen. So we have 3 types of estrogen, 1, 2, 3. We'll get into those a little bit later, but that's basically what that is saying. And those are from the alpha beta cells, receptors in the ovary and the placenta. So this is a big one. So I'm going to write it over here. So this is our estrogen is over here. We are going to get our primary and secondary female characteristics from estrogen. And that would be your breast, uterus, all that development. And then we are going to be in charge of proliferating the endometrium. So obviously very important for the menstrual cycle. Mammary gland, so working on the breasts in preparation if we need it, as well as development. And then we are going to be working, if you do end up pregnant, on fetal adrenal gland development. Estrogen is very important for that. And then also utero-placental blood flow. So very important for more related to when we are getting kind of ready for delivery of pregnancy. So that is basically what estrogen is going to be in charge of. So I'm just going to put a line here. There we go. So now testosterone. So what does testosterone do for the female? So we're looking at libido, sleep, basically anabolism, being able to build up that protein. Also growth of muscle and bone, acne, just like it was for men, but not as, in men, it's really the only one that's causing acne. It's not the only one in female that's causing acne, but it does contribute to it. Also, pubic hair, basically the sebaceous glands too. GnRH, again, stimulating FSH and LH from the pituitary. So then we're talking about FSH for the female. So what does it do in the female? So what it is going to do is development of the primary follicle and also estrogen secretion. So luteinizing hormone for the female, what is that going to do? So luteinizing hormone is going to trigger ovulation. And then it is also the development of the corpus luteum, which we'll get into later. So inhibin in the female, so what is this going to be in charge of? Same thing. So this is going to inhibit FSH in the pituitary, in the AND pit. And that'll be important when we get into the menstrual cycle. HCG in the female, so human chorionic gonadotropin. So this is from the placenta, so you have to have really a pregnancy going on for it to be there. So it supports the corpus luteum, and then it's in charge for 7 weeks of producing the progesterone and estrogen. So very important for that support in the first 7 weeks of the pregnancy. Activin, so that comes from the ovary, and that actually stimulates secretion of FSH from the pituitary and works on binding in the granulosal cells. Progesterone, so ovary and placenta. So progesterone is secretion changes, secretory changes of the endometrium, be in charge of quieting the myometrium, and also will prevent lactogenesis. So basically you're not ready to secrete milk yet. Relaxin, so this is from the corpus luteum, myometrium, and placenta, and this basically is going to work on the pelvic joints and get the hips area, the pelvic area, ready to deliver the baby. So basically facilitate childbirth. All right. So that is the synopsis of the reproductive hormone summary. If you didn't get all of it and you can't understand my writing, it is in your book. It is a very important slide. You will probably see it really understanding the big name, obviously estrogen, testosterone, luteinizing hormone, follicle stimulating hormone, and what they do on each side. So I color coded it. So estrogen or action female is all going to be in pink, and then we'll hide that one. And then the blue one will be your men, all right? Not to be too cliche, but it does kind of make it hit home a little bit. So we have pink or we have blue, all right? So, like I said, you have that sheet. I will have it uploaded, and then you can fill it in. I would make 2 copies because there is a lot of writing related to that. If you miss something on the slide, then you can go look it up, and it's on page 727 in your book. Why does all this matter? So just what you need to be cognizant. Remember, I said I'm not talking about much of testing on any of these systems, but I want you to be aware of. So why do we do testing? We're really looking at infertility, right? So the main position is to get reproduction going. So if something's not working and you're not able to conceive, we have to start looking at the reproductive system. You're looking at all kinds of functional things. So if there's something wrong with the functional tract, is there something wrong with the hormonal assays? Are you able to have normal, basically, release of FSH and LH? Really takes into consideration all of those things to find out where the infertility cause is. We also need to do it on both sides. So it's not just female. So we have to be able to, that FSH and LH. We got to look at sperm. and see if we're getting that influence. So understanding that, you know why we're testing what we test. Also then endometriosis or any other structural abnormalities that cause some type of pathogenesis down there. So that would be what you're looking at. STIs, which we're going to talk about later, are huge. So they're basically sexually transmitted infections.